Good morning to everybody who is attending my lecture series. And today I am discussing the diabetes mellitus and anesthesia. Summary of recommendation for glycemic, blood pressure and lipid control for adults and diabetes. HbA1c less than 10%. HbA1c less than 7%. Blood pressure less than 150/80. And lipids, that is LDL cholesterol, is less than 100 mg/%. Goals should be individualized based on the duration of diabetes, age or life expectancy, comorbid condition, known cardiovascular disease or advanced microvascular complications, hypoglycemia or unawareness, and individual patient considerations. Postprandial glucose may be targeted, or if the A1C goals are not met despite reaching the preprandial glucose goals. Major glucotoxicities. Number one, non-enzymatic glycation of cellular process. Accelerate the atherosclerosis, promote the glomerular dysfunction, induce the endothelial dysfunction, reduce the nitric oxide synthesis, and gross cross-link of the proteins, which enhances the stiff joint syndrome, reduce the wound healing strength, aggravation the ischemic damage to neurological system, cardiovascular system and the kidneys. Description of autoregulation, lactate accumulation, increased vulnerability to the infections, impair the chemotaxis and phagocytic activity of granulocytes, reduced intracellular killing of pneumococcus and staphylococcus, delayed wound healing and dehydration, increased glucose metabolism via the sorbital pathway, promote the intracellular swelling by favoring the production of non-diffusible large molecule like sorbitol, increased blood viscosity. Good morning, everybody. This includes the glucose utilization, decreased contractility, and predispose to arrhythmias. High levels of glucose can promote the non-enzymatic glycosylation reactions leading to formation of abnormal proteins that may decrease the elastins responsible for the stiff joint syndrome, fixation of the occipital joint, making intubation difficult, and wound healing tensile strength. The glycemia disrupts autoregulation. Glucose-induced vasodilation prevents the target organs from protecting against the increases in the systemic blood pressure. Recent information on the relationship between blood glucose and neurologic recovery after a global ischemic event may have important implications for perioperative diabetes management. The possibility that blood glucose is a determinant of brain damage after global ischemia is supported by studies of global and focal CNS ischemia. Data are accumulating that suggests that a major effect of the hyperglycemia is to disrupt the autoregulation, making the arteries and arterioles, that is macrovessels and microvessels, vulnerable to the force disruptions caused by increased blood pressure. Glycemia appears to disrupt autoregulation by enhancing by the activation of protein kinase C. Until better data are available, most recommended that the diabetic patient about to undergo surgery is which hypotension or reduced cerebral flow may may occur should have been a blood glucose level below 2 to 5 milligram per day, per 100 ml. During the period of cerebral ischemia, the two other special situations can also alter how tightly one should manage the patient's glucose level. Number one, surgery requiring cardiopulmonary bypass. And number two, surgery to in pregnant patients or in patients already suffering from diabetic ketoacidosis. To the end of this today's lecture series. We will come with more information in my next lecture. Thank you.